Okay, afternoon everyone. Great to be with you today, and thanks to Dave for asking me. And when he asked me, I thought, this is not my natural comfort zone, so am I going to accept this gig? But Dave's co-chief investigator on a trial we're both running along with the York Trials Unit and various others, focusing on antifungal use in acute leukemias as opposed to chronic leukemias. So, and Dave's been a great support as a co-chief investigator. So I thought, yeah, I'll have to take the gig. But I'm slightly out of my comfort zone. I'm really happy to admit it. But I've enjoyed actually preparing for the talk. Because what I find is when you stay in your own comfort zone, firstly, you don't learn. Secondly, it doesn't tend to, or it doesn't always lead to research ideas. And actually, a few research ideas sort of popped up as I was preparing for this talk. And I don't know about you, I think sometimes it's also healthy for people from slightly from the outside to come in and look at a field as opposed to the same people from the inside talking again and again, because those people always have biases and agendas. And of course I have biases and agendas, but they're from the outside, not the inside, and it does make a difference. So hopefully my talk will be of interest to you. I'm very well aware you're a quite well-versed, educated group when it comes to CLL. There are some technical slides here, but don't worry about that, okay, because it's really to remind me to say something as opposed for you to interpret. So don't worry about anything that goes, oh my God, what does that mean? You know, so don't worry about that. It's really just to remind me to say something, and then if I say anything stupid as we go, you can pick me up at the end, okay? But I thought I would start with this slide, and this is the slide that I use in a lot of infection talks I give, regardless of the type of patient I'm talking about, the type of infection I'm talking about, and it's relevant for all infection in all patient groups anywhere in the world. And it's this continuum of exposure, colonization, infection, and then obviously clinical outcomes in terms of what happens to you when you get an infection, and so on and so forth. And I think it's important to have some concept here because, for example, and I can't think of a single infection where you do not get colonization first. So you always get colonization before, with a bacteria or a virus or a fungus or whatever. You always get colonization of the human body first before you then go on and develop infection. Now, colonization with whether it's a virus or bacteria, that can sometimes be for a very, very short period of time, and it can sometimes be for a very long period of time. And what's also important to understand is many infections we get as humans, whether you have CLL or not, many of the infections we get as humans are actually caused by bacteria or other microbes that actually live in or on us. They are effectively our own bacteria that sometimes cause the problems. And on other occasions, exposure is really important because they don't normally live on us, but we're exposed to them, and then they colonize wherever they colonize on the human body, and then they may or may not cause infection. And of course, when a virus or a bacteria colonizes a human, in the main, probably even in CLL patients, in the main, it doesn't go on and develop infection because there's so many of us. So think about all the people in the world all the time being exposed to viruses and bacteria. And actually most of us don't have infections at any one time. So in the main, when you're colonized with something, it doesn't progress to infection. You get immune response to it or whatever. It doesn't progress. But of course, in some of us, for a whole variety of complex reasons, it does progress. Now, this sort of continuum is important because it tells us something about how we can intervene to prevent infection. So if you think about hand hygiene in the hospital setting and indeed in the community and all the other basic infection control measures we take in the hospital setting, then they predominantly impact at the sort of exposure colonization level of the continuum. But if you think about vaccines, vaccines are interesting because they can actually have action or impact at any point at this continuum, except perhaps at the outcome, because it's too late then. So some vaccines, for example, actually prevent colonization, and that's how they work. Some vaccines don't prevent colonization, but they do prevent progression to infection. And some vaccines actually don't prevent even progression to infection, but they do mitigate the outcome of infection, i.e. the severity of that infection is a lot less severe than it otherwise would be. And actually COVID-19 is a really good example of that, because that, whilst it can for some patients prevent colonization, actually for some patients it's predominantly about mitigating the severity of the infection they subsequently get. It doesn't necessarily always stop infection developing, but it does stop you being admitted to hospital, hopefully stops you being admitted to hospital or being admitted, even worse, to the intensive care unit and so on. So I think having some concept there about that continuum gives us some insight about how one may think about preventing infection. So when I was sort of preparing for the talk, I spotted this study. It's an Italian study, and culture is really important in these sort of studies. But it essentially asked a very large group of patients in Italy, actually, about CLL patients, about what was really important to them in their disease. And infection came out as the number one thing that they were worried about or concerned about. And interestingly, patients in the so-called watch and wait zone were more worried than patients in the treatment zone. And hopefully it should actually be the other way around, and I'll show you why that's the case as we go through the talk. So I thought that was interesting. I thought it was a sort of good sort of starting point. And then there was this study, and this is quite a large, I don't know if you're aware of it, but a large study, vast majority of patients from rich sort of developed countries, so you know, should be predominantly receiving state-of-the-art treatment for their CLL. But interestingly, 1 in 5 patients were completely unaware that there was any risk of infection associated with CLL. And now I have no idea whether that's the case in the UK. I have no idea, to be honest, what the answer is from a UK perspective, but these were all UK-like countries, I think included some UK patients, and 1 in 5 were unaware. So I suppose that what that emphasises to me is that sometimes being informed is different to being aware. They're not the same things. And I think from a health professional point of view, and of course you're a patient advocacy group, from a patient advocacy group aspect, it's important to remember that some patients actually may not be aware that they have a higher risk of infection, and keep sort of repeating that message as you move through your sort of care pathway. Because actually, when it comes to infection and preventing infection, awareness is really, really important. If you do nothing else, even if you don't do any other intervention, but you're aware, actually, that's really, really helpful and important. So I thought this was a really interesting study. This was a study that looked at CLL patients in the decades in the run-up to their diagnosis. And what it showed is that even for decades before they're diagnosed, patients with CLL have higher antibiotic use than patients without CLL. And it's particularly true, particularly high in the 6 years prior to diagnosis. And I think what that attests to is the subtle decrease in your immunity, increasing your risk of infection, leading to you going to your GP more as a sort of CLL population and receiving more antibiotics. I do not think antibiotics cause CLL. So I just want to emphasize that point. This is about your subtle decline in immune system even before you are diagnosed, such that at diagnosis, for example, CLL patients will have used about 20% more in terms of antibiotics than a non-CLL patient in the population. And that's predominantly antibacterial, so classical antibiotics. It's also antiviral agents, antifungal agents, but you're really glad to know it doesn't include anti-helminthic agents or so that's anti-worm drugs, okay, or anti-protozoal agents. And of course, those infections don't tend to be very common in the UK Anyway, so it's predominantly, as Dave said, bacterial and viral infections are the main concern for CLL patients. So it's predominantly antibacterials and antivirals with some antifungals, but above and beyond what you would expect in the general population. And then I suppose the key question is, what sort of infections do CLL patients get? And don't worry about interpreting these graphs too much. And I don't know, can we take this bit off at the top, maybe? I don't know if that's possible, but anyway, there's sort of unmute and all that business at the top. But if you can't, don't worry about it. But what this graph essentially shows is that over quite a long period of follow-up, CLL patients, about 1 in 3 CLL patients with a secondary immunodeficiency, as defined by levels of immunoglobulins, had in fact suffered at least one severe bacterial infection, and patients with high levels of immunoglobulins actually were less likely to have a severe bacterial infection, about 15% of patients overall. And predominantly, when you break those infections down, those severe infections down, predominantly actually we're talking about severe infections now. These are the infections that land you in hospital, not necessarily the infections that your general practitioner might treat, or you might just treat yourselves in the community. But these serious infections were predominantly bacterial and viral. And then when you break that down further, what you find is most of those infections actually bacterial pneumonia. So respiratory tract, and this is a theme that will run through this talk, respiratory tract infection, when you look at the data, and all these studies are relatively recent studies in the last 5 years, it's bacterial pneumonia and respiratory tract infections that are actually quite important with CLL. It's interesting that Dave said about smoking and respiratory health, so thinking about your respiratory health and the interventions to optimize that, such as the vaccines, which are predominantly aimed at respiratory infections, I think is really important. And then a smaller number of patients with bacteremia. So bacteremia is when bacteria get into your blood. Sometimes you'll hear it called bloodstream infection. And that's a pretty serious infection, actually. So that lands you in hospital. You never treat back, or well, you probably do accidentally, but most patients that get bacteremia will end up in the hospital and will require intravenous antibiotic therapy for it, and then sepsis as well. Now, important thing about sepsis, I'm just going to make a little point about sepsis, because people often use sepsis in a diagnostic sense, and sepsis is not a diagnosis, okay? Sepsis is a physiological state because of an underlying infection, and that's really, really important. So if a doctor ever says to you, you have sepsis, your next question should be, what's the infection causing the sepsis, okay? And that's really important, because you won't manage sepsis properly if you don't think about that. If you don't think about the underlying infection cause of sepsis, you will not manage it properly, because sepsis is not a diagnosis, it's a physiological state because of infection. So I just say that because I say it in most of my talks, and it's a bit of a bugbear, because we have these sort of doctors now, you know, that ring up and say someone has urosepsis, which is sepsis associated with the urinary tract, or they just say the patient has sepsis, and it sort of reduces, you know, one's sort of clinical thinking, I think. So I have a little sort of bugbear in my brain about it. But just going back to sort of the sort of causes of infection in CLL, and this study looked at it in a little more detail. I think it's really important to say that overall, the risk actually remains relatively low, because what you've got to think about is, what's the risk in the general non-CLL population? It's actually very, very low of getting a serious infection. And what happens is your CLL, and it does depend, of course, on where you are with your disease, and that's true, but nevertheless, in the general population, the risk is very, very low. And actually, what's happening, your CLL is sort of nudging you up to maybe the risk being very low or low often. So you just have to make, you know, I think it's really important just put everything in perspective when it comes to infection. But I just pull out the respiratory tract infections, again, and the sepsis, which were certainly higher, quite a bit higher in this study in terms of the numbers and proportions of patients that suffered with those infections. But if you look at something like meningitis, your risk of getting meningitis is still extremely low. It's just a bit higher than the general population. And I think it's really, really important to emphasize that point. So this is looking at, so I mentioned about sepsis and bloodstream infections and sepsis sort of go together hand in hand. Patients who have bloodstream infections often have sepsis, not absolutely always, but often that's the case because bloodstream infection can make patients very poorly. So what sort of bloodstream infections do patients with CLL get? And I think it's really important to emphasize that where you are with your disease and whether you're on treatment does make a difference. So this was a study that followed patients up over a 6-year period, and the blue line there is patients who were on treatment, and the red line were patients in the sort of watch wait, didn't require treatment at that sort of period of time zone. And what you can see there is the rate of bloodstream infections is obviously quite a bit higher in patients on treatment, and that's almost certainly a combination of factors contribute to that. Probably predominantly progression of the disease and decline in the immune system, but also possibly some of the immunosuppressing treatments as well, possibly. So what sort of bacteria cause bloodstream infections? And I pull this up because it is slightly different to the general population. What you see in the general population when you look at bloodstream infections is that the most common by far is E. coli, and that's still true in CLL, okay? And E. coli is a bacteria that's usually, so when it gets into the blood, it's usually predominantly about 50% of patients, it'll be because they've got a urinary tract infection of some sort. About 25% of patients, it'll be because of a gallbladder infection or a liver infection of some sort. And then the other group of patients is sort of a hodgepodge of infections, but often things like sort of a diverticular abscess, so elsewhere in the abdomen. So they're the sort of infections, E. coli, and that's still top of the list in CLL when it comes to bloodstream infections. In the general population, the next organism down is always Staph aureus. It's always second to E. coli. And Staph aureus causes a variety of infections, including cellulitis, other skin and soft tissue infections. It can occasionally cause heart valve infection. It causes abscesses, and it causes bone and joint infections. I deal with a lot of bone and joint infections. Staph aureus is the predominant cause. But in CLL, actually, Staph aureus moves down into third place, and it's Streptococcus pneumoniae, which is in second place. And Streptococcus pneumoniae in the general population would be further down. And that, again, attests to that risk I've already mentioned, is the association with CLL and respiratory tract infections. And Streptococcus pneumoniae does exactly what it says on the tin. The pneumoniae bit, pneumonia, it's the number one cause of bacterial pneumonia everywhere in the world, full stop, including in the UK, and that's true in the general population, but it's also particularly true in patients with hematological malignancies, including CLL, and that association has been recognised for decades. There is a strong association between hematological malignancy and pneumococcal Streptococcus pneumoniae infections, predominantly pneumonia. About 85% of those patients have pneumonia. Sometimes pneumococci cause other types of infections. People often worry about fungal infections, but as I mentioned before, I think it's really important to put fungal infections in perspective. So this was a large, I think it was, almost all of these studies are performed in Scandinavia. They seem to do a lot of research on infection in CLL, actually, mostly Scandinavia, mostly in the last 5 years, and mostly large studies, many of them at population level. And this is a large study of almost 800 patients, 32 years of follow-up, although the average for each patient was about 8 years. So long follow-up study. 4 out of 10 patients were receiving or had received treatment during the follow-up, and about 1 in 11 patients suffered a serious bacterial infection, but less than 1 in 50 patients had suffered a serious fungal infection. And really importantly is the last bit, which is that serious fungal infections were almost entirely associated with advanced disease being treated with the chemotherapies Dave was talking about this morning. And not only that, it was patients who'd had at least 4 chemotherapies sequentially that were much more at higher risk of fungal infections. So it's always important, whilst we all worry about infections, I do as a doctor, I'm sure you do as patients, it's always really important to put this sort of information in context, because if you're early in your diagnosis or you're at a stage where you don't require treatment, then your risk is actually very low for something like a fungal infection. Now, you might have heard the word opportunistic infection. That's often, sometimes used by doctors. You may have come across that term. So I'll just explain it. These are infections that actually in the general population you hardly ever see. So they're very unusual in the general population, or relatively unusual in the general population. The incidence of them would be very low in general. But in immunocompromised patients, they become a little bit more common. But it's really important to emphasize it's only a little bit more common. Okay, so they become more common, and therefore we worry about them more. You worry about them more as patients. We worry about them more in clinical practice. But again, it's very much associated with where you are in your disease. So again, if you're relatively early in your disease, this is not something you should really realistically be concerned about. It's very unlikely. But again, you know, if you have a more advanced disease and you're on quite a chemotherapy regimen of some sort, then it may be more of a consideration for you. I'm going to come on to the current national guidance about how to prevent infections in CLL, and of course it links to that. But there's just 2 things I wanted to point out. You probably can't read that, but one of them is shingles. Okay, so looking at this data again, what tends to happen with these sort of opportunistic infections is in the general population the risk is very low, and then in the CLL population the risk is still, you know, very low or low, if you know what I mean. What is not happening here is you're moving from very low in the general population to very high in the CLL population. That's not what's happening here. But having said that, there is a high risk of shingles associated with CLL, and I don't know how many people have had shingles. Yes, I've had shingles. It's nasty. And I suffer with post-herpetic neuralgia, so I know exactly what that means. So it's a really nasty condition. So I just emphasise that, and it'll come on to something I say a bit later on. And then, you know, sometimes people worry about this weird fungal pneumonia, pneumocystis pneumoniae pneumonia, which some of you may be familiar with and some of you may not be. And this is the pneumonia that classically was very strongly associated with advanced HIV and the immunocompromise associated with that, but actually increasingly over the last decade or 2 has become much more common in immunosuppressed patients, and that's because of all these fantastic drugs sort of Dave was talking about, but the risk is still very low. So certainly the risk is higher, but we predominantly see these infections again in patients with more advanced disease taking often very specific chemotherapies, not necessarily associated with all chemotherapies one might receive. And then, and then just to put everything in a bit more perspective, is your risk of dying of cardiovascular disease is 6 times higher than your risk of dying of an infection with CLL. And your risk of dying, Dave mentioned other hematological malignancies, for example, or other cancers. Again, if you add those 2 together, it's about 6 times higher than infection. So putting infection into perspective, the risk of infection, I think, is really important. Think about your cardiovascular health, because that's statistically much more likely to kill you. So we can predict to some extent, we have scoring systems now, and I'm going to skip over them for sake of time. We do have scoring systems now that can, to some extent, predict the risk of infection in CLL. I'm happy to talk about that. And they can potentially categorize you into high, medium, and low risk based on things like age, your immunoglobulin levels, the stage of your disease, and various other things. And actually, some of the, you're going to hear about data science in the next talk, machine learning, we all hear about that. Some of us worry about that, of course. And we have other emerging fantastic technologies like omics. And I think the power of these new technologies will not be using them in isolation. It'll be synthesizing them together. And they will be very powerful in clinical practice, I suspect, over the next decade or two. And it'll be interesting to see where they take us. But this was a study using machine learning approach. We're seeing quite good at predicting infection, using actually information readily available to your local friendly hematologist. So I'm going to skip over that. So really, in summary, early in your disease, the risk of infection is probably quite similar to, or pre-diagnosis, your infection risk is slightly higher, but similar to general population, and the sort of infections you get will be very similar. That's true in the watch and wait zone as well. The risk a little bit higher, but nevertheless sort of infections that the general population get. And then when you get to more advanced disease in the treatment phase, and it very much depends on individual treatments and so on and so forth, there may be specific infection risks of opportunistic infections, but a really important point here is that your risk at that stage with more advanced disease of the common infections is still a lot higher than the opportunistic infections. So I know I'm probably, the national guidance, okay, so I just want to skip over it quickly. You're probably quite aware of this. Dave mentioned vaccinations. Have vaccinations early as possible after diagnosis. That's the key thing when your immune system is more likely to respond to them favorably. Pneumococcal vaccination, the 2 conjugate and the polysaccharide vaccine, they're absolutely the most important vaccines in CLL patients. But annual flu is important too, including in household members, and likewise COVID. Now, you're probably aware that recommendations this spring were for immunosuppressed patients to get a booster dose. I don't know what's going to happen in autumn. The recommendations are not out yet. I suspect you will be recommended to get a dose in autumn, but after that it may be yearly. I've already mentioned shingles. So think about that. You get it free on the NHS, the vaccine, if you're 70 to 79 years. It's not a live vaccine, so it's safe to have. If you want to have it early, you'll have to pay for it privately, my understanding is, and avoid live vaccines.
It's available free for the immunocompromised.
Oh, is it? Sorry, I didn't know that. Okay, that's great. We'll go and get your shingles vaccine then. That's brilliant. Okay, I paid about 75 quid for it. I wasn't aware of that, actually. Yeah, I think it's quite a recent thing, though, isn't it? Yeah. Avoid live vaccines. If you're ever worried about vaccines, go and read this green book. Okay, it is technical. Okay, but it's actually quite accessible as well. It's open online. I read it all the time. Well, not all the time, but dip in when I'm really bored and, so can't sleep at night. So, but it is a really good resource, and it may reassure you if you have concerns about vaccines. Antibiotic prophylaxis is for a selected group of patients with recurrent and/or serious bacterial infections. Sometimes, I mentioned that pneumocystis pneumonia, that sometimes prophylaxis against that is warranted in certain situations if you're taking certain chemotherapeutic agents. And the guidelines advise on that. Again, the national guidance openly available to everyone, so go and have a look. It's not bad. It is technical, but it's not terrible read for, I think, a patient. I think you could certainly get something from it, so go and have a look, be informed. Fungal prophylaxis is not generally recommended because the risk isn't that high, but that's maybe a space to watch as increasing research evidence emerges about some of the new agents we're using. Immunoglobulin replacement therapy, Dave mentioned this. Again, this is even now, I think, for a more select group of patients who have had documented failure to respond to vaccination and have low immunoglobulin levels and suffer from recurrent to severe bacterial infections despite 6 months of continuous oral antibiotic prophylaxis. When I say prophylaxis, I mean prevention. I'm going to skip over that for time. I think exposure is important. Okay, think about exposure. The most important thing to prevent infection is hand washing. full stop. Obviously, think CLL patients from the literature certainly a higher risk of respiratory tract infections. So things like cough hygiene, respiratory tract hygiene, including the people around you, probably more important than you yourself, but including you, obviously, particularly if you're sitting in outpatient clinics, for example. And there may be specific times to think about exposures, such as when you're travelling abroad or something like that, when you should go and get advice. COVID, we have pretty good treatments for COVID now, certainly for severe. COVID is not the problem it was in hospitals. I can't remember the last time I saw someone really sick with COVID in hospitals. We still get patients with COVID in hospitals, but nearly always it's not the predominant reason for them being in hospital, and it causes us some problems from an infection control point of view, but actually it doesn't tend to cause too many problems for the patient themselves. But having said that, occasionally you will get the patient that develops severe inflammation in the lungs associated with COVID, and we have steroids and tocilizumab potentially for those patients now, and they're pretty effective, and I think that's why we don't see any. I can't remember the last time. I mean, I do regular on calls. I can't remember the last time I was phoned from ICU about a patient with COVID. Because they were on ICU with COVID. Nearly always it's almost an incidental finding now in patients in the hospital setting. And then for patients that are high, including CLL patients at high risk of progression to severe disease, but oxygen isn't required, and that would be in the community and in hospital setting, then we have an antiviral and a monoclonal antibody. The monoclonal antibody is probably not that good, frankly. The antiviral is better, but the problem with the antiviral, it does interact with quite a lot of other drugs. So it depends what else you're taking. And a key message is about, what's in terms of your infection risk, this concept, which is actually used across all groups of patients with immunosuppression, this concept of the net state of immunosuppression. What is your net state of immunosuppression, I think is absolutely key. So that includes some of the risk factors I've already mentioned, like the stage of the disease, the treatment you're specifically taking for your CLL, if you're on treatment, your immunoglobulin status, and various other things. If you've never had an infection problem, that's really good. Whether you've been on treatment or not, that's really, really good, because that's a really good sign. That's a good prognostic sign. You've never had a problem with infection. Clearly, if you've been out of hospital with 5 or 6 infections over the last 2 years, that's a completely different scenario. So thinking about your net state of immunosuppression, and of course the clinicians should be doing this as well, is important. But at the same time, we all have a responsibility. And you heard at the beginning, my career has been about antibiotics and antibiotic stewardship, which is really about using antibiotics sensibly. Getting the balance right between using antibiotics sort of willy-nilly and using them sensibly is really important, even in immunocompromised patients, even in patients who are slightly more at risk than the general population, because antibiotics do have adverse effects. 1 in 5 patients who takes an antibiotic in hospital, for example, or receives an antibiotic in hospital, will have a Kerr pathway changing adverse effect. So an adverse effect that changes their clinical Kerr pathway. Most people don't know that. Most clinicians don't really know that. So getting the balance right between willy-nilly use of antibiotics and using them when they're really needed, when they'll genuinely impact your outcome, is really, really important. And it's important because of antibiotic resistance. We don't have numerous sort of antibiotics, and the pharma industry is not going to bail us out on this over the next 10 years or so. So we're running out of effective antibiotics. Even in the UK, antibiotic resistance is a problem. It's fueled by antibiotic use, so we just need to make sure we're using antibiotics when we really need them. It's a challenge, there's no doubt about that, and it's much more complex than this slide. But it's something we all have responsibility as responsible society, citizens of society, to think about. And if there's time, happy to take any questions or grab me before I leave. That's no problem at all. So thanks for your attention.
Okay, thank you. What I will say is that we have the leaflet in your pack, which is your vaccination leaflet, and there's a table at the back which talks about the various vaccinations, including Shingrix.
And the national guideline actually says you should keep a log. So it's a good idea to keep a log so you know where you are. Because actually when you ask patients about vaccination, which we do as infection doctors, not necessarily always CLL patients, they very rarely can tell you actually. So it's really good to keep a record. Yeah.
So thanks, Gavin. I'd just like to reiterate one thing about the shingles vaccine. So previously persons with CLL were told not to have the shingles vaccine because it used to be a live vaccine. But as you say, that advice has now changed.
Yeah, it's not a live vaccine.
And as you say, it's not age restricted now for persons. So strongly encourage everybody to have a shingles
But
vaccine.
some of the confusion here at the moment comes with the chickenpox vaccine. The chickenpox vaccine is a live vaccine. So don't have the chickenpox vaccine, you need the shingles vaccine, which is not a live vaccine. So sometimes there's confusion about that, in the same way that sometimes people are confused about infectivity of shingles and chickenpox. Dave's a really good point, Dave.
So absolutely have the shingles vaccine.
And I would, regardless of your age, I would have the shingles vaccine anyway, because people don't take shingles seriously. It does land people in hospital, and even if it doesn't, it's post-herpetic neuralgia, and I can attest to this personally, is a really nasty condition. So which will keep you awake at night. So have
and the
it.
other thing with respect to COVID, so Dr. Frigo and myself were just thinking about the same thing about COVID pneumonia. We can't remember the last time we had somebody on the ward with a serious...
And it's unusual in all patients groups now. Occasionally, and I was sorry to hear about the lady somewhere down here that had frequent COVID. We do see patients with sometimes have that history of frequent COVID, but actually we do see patients also that have frequent colds and other respiratory tract infections, and there may or may not be specific reasons for that. And if you're more obviously advanced in your disease with a low immune system generally, that may be linked in with that. It's a difficult challenge, because it's we don't see COVID fortunately making people very sick anymore, but we do see COVID still being a nuisance, and sometimes a big nuisance for people. Still impacts their lives, and I guess it just make sure you have your booster vaccines. Actually, the data on CLL patients responding is pretty good. They don't respond quite as well as the general population, but you do respond pretty well actually. But it will be dependent on where you are in your disease progression. And maybe some other factors as well. But I think, I'd strongly encourage you to just keep up with your COVID boosters. That's all. Yeah, I can ask. I'm happy to answer anything more specific. But
So thank you again, Gavin, for a very informative talk.